So the machine learning artificial intelligence technique to grade mitral valve regurgitation by severity among 139 is one of the studies that's made after 2020. It shows that 99.5% accuracy for identifying a normal mitral valve and exceeding the 99% accuracy for identifying the severity of the mitral regurgitation, either mild, moderate, or severe. What about the workflow in the echocardiography lab? With advances in artificial intelligence, image acquisition protocols will group relevant images according to the clinical relevance. يعني ببساطة أنت لما هتدخل الإيكو لاب هتبتدي تاخد السيريال acquisition بتاعتك. مش هبتدي بالطريقة العادية اللي هي apical, parasternal long axis, so then short axis على 3 levels and apical 4, apical 2, apical 3. No, here the machine learned about the disease you are asked for. So if you get the left ventricular wall motion assessment, you will display all cine images of the left ventricle. If you are seeking help about aortic valve stenosis, the machine would display the 2-dimensional, 3-dimensional LVOT images and the pulse wave stroke volume transvalvular Doppler tracing to assess the continuity equation. And then the peak aortic valve transvalvular Doppler gradient to assess the severity. Once again, after 2020? After 2020, we have full automation. You do not have man-made assessment for your echo study. The full heart assessment model, which is released by one of the vendors, which Philips. Actually, this is written in all literature. So we have only 2 vendors for full automation, the Philips with its machine, EPIC, CVX, and the Siemens company for full automation. The valvular heart disease, you can get the valve location, the valve landmark, and valve surface, and then this will help you in all transcatheter mitral valve implantation, where there is a risk to obstruct the LVOT when you, for example, insert a mitral clip or a mitral valve prosthesis. In addition, you have a tracked mitral and aortic valve models in several frames within the cardiac cycle. You can see here how the aortic valve is open and the mitral valve is closed, semi-open and semi-closed, and mitral valve open and aortic valve closed. Here, you can judge mathematically and geometrically the relationship between the position of the aortic and the mitral valve to help you inserting a proper TAVI procedure on aortic valve catheter implantation or even mitral valve clamp. Again, the mitral annulus is very enthusiastic field. Actually, the mitral annulus is a miracle. Those who understand the miracle of the shape of the mitral annulus know very well how much the artificial intelligence can help in delineating the disease of the mitral annulus. I will let you with 30 seconds about this video about left atrial myxoma. You can see the journey starting from the 2D images up to the 3D images, and then you can see how the artificial intelligence could help you for assessment of such a disease. Here you can see the myxoma size, and you can assess it by 2-dimensional echo, and here the artificial intelligence could help you see how much it's related to the interatrial septum, how much it can pass into the left ventricular inflow. And you can see by artificial intelligence what's called the 3D true view. And the true view make you like the intracardiac echo. And then came what's called the glass view. The glass view can show you exactly how much this disease is related to the nearby structure. So what's about the era of COVID-19? Mayo Clinic uses artificial intelligence to help assess cardiac danger from COVID-19. Actually, the frontline physician, could you give me 2 minutes? The frontline physician in the COVID era came to manage the patients. Actually, the expert sonographers cannot cope with the pandemic with such disease. So a small handheld devices help this era for assessment of patients needing echo. The first software released in the market after 2020, which is the Echo Go, which is certified by the FDA for precise, proven, and predictive studies. And this from the Journal of American Society of Echo about human versus artificial intelligence-based echocardiography analysis as a predictor of outcome in some countries related to the American Society of Echo during the COVID era. And the last study released into the ESC, last ESC in Barcelona about the EchoNet, which is a randomized controlled blind study for sonographers versus artificial intelligence assessment, and include that it is it is non-inferior and superior to initial sonographer assessment. So what about the limitation of this test? Limited knowledge of the use of automation among patients with significant conduction disease. This is a still limitation. The poor or fair quality images, the enormous border tracing by the computer. Came to the golden question, will artificial intelligence replace the echocardiographers? Actually, not anytime soon, and cardiologists must prepare themselves to document the artificial intelligence effectiveness. So, to conclude, artificial intelligence algorithm can increase efficiency and accuracy in echocardiographers by reducing human variability. Thank you very much.
شكرا دكتورة عزة. دكتورة عزة بتحب تقول كومنت؟ طبعا الارتفيشال انتليجنس
جاوبت على السؤال.
الارتفيشال انتليجنس زي ما احنا عارفين بقت في كل مجالات حياتنا. قصة القاضي اللي من اسبوع اللي في امريكا الجنوبية اللي استخدم طبعا عارفين الشات جي بي تي. الشات جي بي تي ده قلب الدنيا، سوفت وير بيستخدم الذكاء الاصطناعي الارتفيشال انتليجنس. هو حط له معطيات القضية، طلع له الحكم، وكتب كده في حيثيات الحكم ان هو الشات جي بي تي قال لي ده جاني ولا مش جاني، وكانت اول مره. فهم بيقولوا انه فعلا في خلال 10 سنين في وظائف هتنتهي زي المحاماه، هتنتهي تماما. هتدخل للجهاز هيدي لك الايه العريضه والحكم وكل حاجه بناء على التجارب السابقه. السباق سريع جدا. انا بيجي لي ايميلات على طول من شركات في امريكا وكندا عايزين CMR، عايزين صور CMR عشان يطوروا الارتفيشال انتليجنس. احنا زي ما احنا شايفين هو لحسن الحظ مش يعني will not substitute الفيزيشنز الدكتورز، ولكن هو فعلا زي ما دكتوره عزه ورتنا هو هيساعدنا جدا في التشخيص. هيبقى سهل جدا ان احنا نوصل لتشخيص قريب بناء على الارتفيشال انتليجنس. الحفظ مش هيبقى مهم في الطب زي زمان. قصه الحفظ هتبقى محتاج كرييشن، محتاج انك تفهم اكتر، لانه الارتفيشال انتليجنس will substitute كل القصه دي. وزي ما حضراتكم شفتوا الدكتوره عزه ورتنا ازاي السوفت ويرز دلوقتي بقت يعني قريبه. سؤالي ليك يا دكتوره عزه، ايه المدى الاكيورسي لغايه دلوقتي في الارتفيشال انتليجنس في الدايجنوزز؟ هل في حاجه في
disease it is 99% زي الاستادي اللي انا وريتها على الاسسمنت اوف mitral pathologies and severity of mitral regurgitation exceeding 99%.
شكرا دكتور عزه، شكرا جزيلا. كان جول last presenter in this session دكتور احمد شحاته هيتكلم على الكاردياك سي تي ريد with expert.
Good morning. It is a very great pleasure for me to be with my professors and colleagues. Cardiac CT have greatly expanded beyond assessment of the coronary anatomy. It have been used for assessment of structural heart disease, congenital heart disease, and the planning for complex percutaneous intervention like TAVI, percutaneous intervention for the tricuspid valve, and percutaneous intervention for the mitral valve. This is the first case. A case have been referred for me for assessment of the right ventricle before percutaneous tricuspid valve intervention. Before we proceed into how to assess this, the devices for percutaneous tricuspid valve intervention lie in either three categories, either annuloplasty device, edge-to-edge plasty, or valve replacement. First, we have to assess the tricuspid valve annulus. in the double oblique view, we have to take the mean arithmetic diameter, short diameter and long one. Then we go for perimeters and the area to drive the actual size of the annuloplasty device. Second, we have to know the tricuspid annulus in the axial view and to have the length of the tricuspid of the right ventricle for the sake of assessment of a spacer system as a device used for percutaneous intervention to reduce the coaptation. This is an axial view, maximal intensity projection image in the CT. And last, we have to know the actual course of the right coronary artery around the tricuspid annulus. This is an oblique view that can describe how the right coronary artery is closed at the inferior aspect of the tricuspid annulus. And this is the volume rendered image, can show the course of the right coronary artery in relation to the annulus. It may go superior, inferior, or at the same level, or it may change its level, come inferior, then superior to the annulus. Lastly, in the assessment, we have to know the perimeters and the mean arithmetic diameter of the inferior vena cava at the cavo-atrial junction and at the level of the first hepatic vein. Then we measure the distance in between if we think of caval valve implantation. This is another case of anomalous origin of the coronary artery. This is the circumflex artery arising from the contralateral sinus, from the right coronary sinus. Then it passes inferior and behind the aorta in a retroaortic course to reach the AV groove. This is usually a benign course, and 99% of the LCX anomalies runs the retroaortic course. This is one of the most important and potential hemodynamic significant courses, which is arising, which is the left main arising from the contralateral sinus, from the right coronary sinus. It may go to the AV groove either anterior to the RVOT and is termed pre-pulmonic course or subpulmonic course, or it runs septal course deep in the upper part of the interventricular septum, or passes in between the RVOT and the aorta, running an interarterial course to reach the AV groove. In the past, this is the mechanism of potential high risk of sudden cardiac death or ischemia with a scissor-like technique. During exercise, the aortic pressure rises and the RVOT pressure, pulmonary artery pressure rise, and the coronary artery compressed in between. However, this theory couldn't explain because the pressure in the left main also increased during exercise, and the pressure in the pulmonary artery is less than the aorta. Then a paper released in the JACC recently described the potential hazard of the interarterial course as follows. We have anatomic variant and we have functional variant. The anatomic variant describes the intramural course of the anomalous origin and describe the tubular hypoplasia, and the dynamic portion, the acute takeoff. In the lower image, we can see the elliptical shape of the left main coronary artery running between the aorta and the pulmonary, and here we can see the angle, and the takeoff is right angle 1. This is an axial view images, maximal intensity projection. In the third image, we can appreciate there is a contrast tracking in the base of the pulmonary trunk, and this is the clue for a case of fistula. Fistula is communication between the circumflex running in the AV groove and leading to a bunch of vessels, vascular network that ramify and end into the pulmonary artery. This is a case of complication after complex coronary intervention. This is a case referred for assessment because of complication and the potential hazard to the ascending aorta. We can see here a PTCA wire that is free floating in the ascending aorta and is trapped behind under-deployed and missed stent in the left main LCX. In the same patient, he sustained myocardial infarction with LV thrombus, and when we expand the field, we can see embolization to the brachial artery. This is a case 16-year-old female that is referred for assessment of the aortic valve. We can see the aortic valve is doomed and much thickened. When we take double oblique view, we can appreciate it is a unicuspid, unicommissural aortic valve stenosis. We can see an eccentric opening reaching the lateral aortic wall described as a teardrop shape for the, meaning this most probably unicuspid unicommissural. In the below images, we can appreciate there is left ventricular hypertrophy where the septum approaching 14 millimeter. This is the histopathology of unicuspid aortic valve stenosis. This is the raphe between the commissures. This is the raphe, and this is the eccentric opening, and this is the teardrop or exclamation mark. This case of unicuspid aortic valve is much more benign than the unicuspid acommissural valve, where the opening is central and smaller and present early in the infancy and more severe. While our cases is eccentric teardrop, larger opening, usually present in the adulthood. This is a case of outpouching of the left ventricle, which is large during diastole. This is taken at 18% of the cardiac cycle, and this is taken at 40% of the cardiac cycle. During systole, there is contraction of the myocardium and the diverticulum much smaller than during diastole. Outpouching of the left ventricles means three differential diagnoses, either pseudoaneurysm, a true aneurysm, or left ventricular diverticulum. Pseudoaneurysm is the worst prognosis. This means most probably rupture of the myocardium that is contained within the pericardium. And the true aneurysm, narrow neck and comprised of the all myocardial tissue. However, it became fibrous tissue and carry the risk of arrhythmia, thromboembolization, intractable heart failure. The true left ventricular diverticulum, either muscular type, which usually arise in the apex, but in our case, it is a lateral wall of the left ventricle. The natural history of this disease, there is no existing information. The body of literature is very small in this aspect. However, it has the same potential complication of true aneurysm. This is a case of interatrial septal defect, a huge interatrial septal defect with shunt, and the right ventricle is hugely dilated, trabeculated, and the right atrium is large. CT can also assess the interatrial septum for small diseases. This is the CT can assess also PFO like the transesophageal echo, and this is assessed running in our department. PFO types, either discrete type like this, or a column of blood exists between the left atrium and the right atrium without shunt, and this is called open PFO without shunt, and this is open PFO but without shunt. There is the trickling of the dye in the right atrium. Thank you.
شكرا دكتور احمد شحاته. اتفضل دكتور محمد عنده سؤال. اتفضل.
انا عارف ان احمد شحاته اكسبرت في السي تي اي. احنا لما بنشوف عيانين الكوروناري ارتري ديزيز particularly patients with chronic angina, chronic stable angina. If the patient is high risk, الحكايه بتبقى سهله جدا لان بنحول العيانين دول coronary angina, invasive coronary angina. The problem in the patients with low risk and intermediate risk, we have two groups of tests. Anatomical test, essentially CTA, and the functional test, which is any form of stress. They say that if you are looking for the atherosclerotic burden, then you prefer anatomical test. And if you look for ischemia, you prefer functional test. Could you tell us exactly which kind of patient is preferably transferred for anatomical testing by CTA, and which type of patients should be subjected to functional tests instead of anatomical tests?
CT is very good in evaluation of the anatomical of the coronary anatomy. However, it can be also used for functional assessment with the advance of the CT derived FFR, which most probably will be available soon, even in Egypt. Patients referred for CT, usually patient with pre-test probability if it is low or it is intermediate. But if the pre-test probability is high or intermediate, the patient should go for assessment of functional testing like MPI or dobutamine echo or any form of stress imaging modality.
شكرا دكتور احمد. انا بشكر السبيكر والتشيرمان. It's very good session in the image. We close the session to start the second one. Thank you very much.
صباح الخير. اولا بشكر الاورجنايز كوميتي، والموضوعات اللي اتقالت ديت موضوعات تليق باسم القلب والسبيكرز كمان. هنبدا السيشن الثاني عن الهايبرتنشن، ويسعدني يكون معايا الاستاذ دكتور رملي ودكتور سامح بخوم. هنتكلم على الديفايسز which device to use to diagnose hypertension. واظن احنا لينا اكسبيرينس، احنا عملنا ستادي في حوالي 3 سنين وشويه، طلع ان 81% of our devices is out of function. دكتوره غاده اتكلمنا على which device to use to diagnose hypertension. اتفضلي.
شكرا جزيلا لحضرتك. Good morning my professors and my colleagues. I'm thrilled to be here today among my professors and colleagues. This talk is about which device to use to diagnose hypertension. Why do we need to measure blood pressure? We need to measure blood pressure because diagnosis and management and follow-up of patients with hypertension need a proper and correct blood pressure measurement. For this, we need validated devices, well-trained personnel, and proper measuring technique. In this lecture, we'll focus on the device. In the market, there are many devices: the mercury sphygmomanometer, the aneroid sphygmomanometer, and the oscillometric devices. And subsets of oscillometric devices are the ambulatory 24 hours blood pressure measuring device and the automated unattended blood pressure measuring device. The mercury sphygmomanometer is being the oldest device to measure blood pressure. They start to use this device since the beginning of the 20th century. It has been the gold standard, the traditional device for blood pressure measurement, and it's been the most commonly used device in hypertension studies. And if it is well maintained, it can last for a lifetime. But this device has many limitations. First limitation related to the technique of measuring blood pressure, the observer error. If the observer had lack of concentration, if the observer has a hearing defect, if the observer can't or fails to interpret the Korotkoff sound, if the observer has bias towards terminal digit rounding, then there will be error in measurement. Second error is related to the maintenance of the device itself. The device needs regular maintenance and comprehensive maintenance related to the physical status of the device, the leakage test, and the calibration test. Another error is the methodology itself. The mercury sphygmomanometer is a device which needs comprehensive complex training for blood pressure measurement. So any errors during measurement will lead to either overestimation or underestimation of blood pressure. And last but not least, the health hazards of mercury. The health hazards of mercury is being described in the 1952 when a famous incident happened in Japan when a factory got rid of their chemicals into the Minamata Bay, and the marine life has been poisoned, and the individuals who ate from these shellfish specifically got neurological diseases which ultimately led to death. Then the Minamata Convention started to ban the importing, exporting, and manufacture of any mercury-containing device, either mercury sphygmomanometers or mercury thermometers, since 2013. And as Professor Dr. Salman Gharib said, a study was done to evaluate the maintenance of mercury sphygmomanometer measuring devices in 50 institutions of the Ministry of Health. They tested 465 devices, and the device, to be effective and proper for measuring blood pressure, it should pass 3 tests: the physical assessment test, the leakage test, and the calibration test. And the results were devastating. Only 6 devices, which represents 1.3%, passed all 3 tests. The aneroid device carries the advantage of not containing mercury, thus there is no mercury hazard. It doesn't contain a liquid, so it can be hanged on the wall, and it is a portable device, yet because it is a device which uses the auscultatory method, so it carries the disadvantage of observer errors and methodology errors. In addition, it is less accurate than mercury devices, and it requires even more frequent calibration. Now, the oscillometric devices being the most commonly used devices and the devices that's been recommended in the guidelines, it doesn't contain mercury, it's easy to use, it doesn't carry observer bias because the device does it all, it doesn't need complex training, it is just pressing a button and then the device will calculate or will measure the systolic, diastolic blood pressure in addition to the heart rate. And now available are smart automated devices which can connect to the smartphones wirelessly and send the blood pressure measurements directly to the physician. But there are many variabilities between manufacturers, and the device has a limitation of not being able to measure blood pressure correctly in patients with irregular rhythms and patients with tremors, and the initial price may provide a financial restraint on the physician and on the patient. A subset of the oscillometric device is the ambulatory blood pressure measuring device. It carries the advantages of oscillometric device. In addition, it measures blood pressure along 24 hours, so it gives an idea about a prolonged real-time measurement of blood pressure. It measures blood pressure at night, and you all know that nocturnal blood pressure has been linked to cardiovascular outcomes, so it's important. It avoids white coat hypertension, can diagnose masked hypertension. In addition, different studies showed strong prognostic impact of the measurements of blood pressure by ambulatory devices. But the problem with the ambulatory devices is that, of course, is a cost. It's not available in many centers. It requires 2 visits to the clinic, one to put the machine on the patient, and the next visit to remove the machine to upload the data. And the inflation of the cuff during night may be troublesome to some patients. The most recently introduced device is the automated unattended blood pressure measuring device. It's an oscillometric device that's fully automated. It starts to measure blood pressure over 30 minutes. Every 2 minutes it measures the blood pressure without need of activation either by the physician or by the patient. The physician should go out of the room and leave the patient with the device. So it has the advantage to avoid white coat hypertension, and it was found that its reading is related or correlated, good correlation with the daytime ambulatory blood pressure measuring device. Of course, it's of very high cost, that's why it's not available in many centers. In addition to the device, you should choose a proper measuring cuff, because choosing a wrong cuff will lead to wrongful readings. We have many sizes of the cuff: pediatric, small adult, large adult, and thigh cuffs. And for requirement of the cuff, it should encircle from 80 to 100% of the arm circumference of the patient in order to give correct measurements. Now, where do we measure blood pressure? We measure blood pressure either at the office or out of the office. At the office, we can use the auscultatory methods, either by mercury or aneroid, or the oscillometric or the automated unattended device. While out of office blood pressure measurement, patients may use the mercury or the aneroid with all the precautions. Or the oscillometric device, it's much easier, and the arm cuffs are preferred than wrist cuffs because it needs many precautions. And the ambulatory 24 hours blood pressure, of course. Why do we need the location where we measure blood pressure? Because the definition of hypertension depends on which device at which location. So the threshold of diagnosing hypertension with office blood pressure measurement is different from ambulatory and is different from home blood pressure measurement. Of the automated unattended blood pressure device, as I said, it was correlated to the daytime ambulatory, but the actual threshold for diagnosing hypertension is not yet described. Before buying a device, you should buy or you should use a validated device. A validated device means an accurate and a precise device. Accurate device means that measurements true to the correct measurement, while precision means that multiple measurements should be close to each other. There are many websites now that are available from the World Hypertension League, from the United States, from the Hypertension Canada, and from the Food and the Drug Administration, which offers a platform to search for validated devices for different occasions. So home devices are different from office devices, are different from devices used for children or for pregnant ladies. What do the guidelines recommend? The guidelines, as we said, now no guideline recommends use of mercury sphygmomanometer because they banned altogether manufacture of mercury devices. The latest guidelines which talk about mercury sphygmomanometer was the Saudi Arabia guidelines in 2018. Otherwise, all guidelines recommend use of oscillometric devices, and if the oscillometric devices is not available, then the aneroid device may be a good alternative. And all guidelines as well, they recommend out of office, in addition to office blood pressure measurement, to confirm the diagnosis of hypertension and to follow up the blood pressure control of patients. What does the future hold? The FDA approved cuffless blood pressure measuring devices. They are not yet being clinically validated, but they are approved by the Institute of Electrical and Electronic Engineers, waiting for studies of these devices. So to conclude, the requirements of a good blood pressure measuring device, you can use any device provided that this device is validated and well maintained, and take care to choose the proper cuff size according to the patient's arm circumference. Thank you.
شكرا دكتور غادة. دكتور محمد تفضل.
Good presentation, no doubt about it. The problem is if you measure the blood pressure by two different devices, you get two different figures. And this is very well seen in the SPRINT trial. The SPRINT trial was based on using the automated blood pressure instruments with measurements in العيان بيقعد في أوضة معزول عنها والممرضة والدكتور بيسيبوه ويقيس البلاد pressure several times and take the average. The difference between the oscillometric measurements and the automated measurement averaged 17 millimeter of mercury. So how can you reconcile these differences and come up with diagnosis of hypertension? One of the reasons انهم اختاروا في الجايدلاينز 130/80 is to get an average between 140 and 120, the difference between measurements by two different instruments. The other thing which I wished you alluded to is using the wrist sphygmomanometer. The wrist sphygmomanometer again is coming back, and there are some modifications because we used to disregard it because you cannot compress two bones, the radius and the ulnar. So the measurements with the wrist sphygmomanometer was annotated as a wrong measurements, but it's coming back again. So if you can comment on the difference between the different instruments and the use of the wrist sphygmomanometer.
هو wrist sphygmomanometers, some guidelines do not recommend up till now the wrist sphygmomanometers, like the Canadian, for example, because it needs the wrist to be stable, not flexed, not extended, and it needs the wrist to be stable at the heart level size. You only recommend the wrist sphygmomanometers for obese individuals whose arms are unsuitable for the arm cuffs. And most guidelines recommend arm cuffs for blood pressure measuring device. Different measurement between the wrist and the arm?
Different measurements in the same setting
If you use mercury sphygmomanometer, you get a figure. If you use the oscillometric, you get a different figure. If you use automated blood pressure measurements, you get a third figure. So
Yes.
what do you do for this?
Oh, it's the same difference that between office measurement of blood pressure and the ambulatory blood pressure measurement. Of course, the definition of hypertension will change because of the change of the location or circumstances of measuring blood pressure. So I think there is not yet a threshold for diagnosing hypertension by automated device, but we can assume that the threshold is similar to the daytime, which is more than 135/85.
هو ده يمكن اللي بيخلينا حتى لو بنعمل 24 اور بلاد بريشر مونيتورنج ديسكارد الفيرست او لاست ريدنج عشان فيهم الوايت كوت افكت. احنا
النايس جايد لاين بتشخص بلاد بريشر بس باي
ambulatory.
but all over the world this is not accepted because it's cumbersome, costly and disturbing to the patient.
لو حضرتك شفت الريزلتس بتاعت النايس جايد لاينز اللي هي بتستخدم الامبولاتري هتلاقي ان هي وفرت في الاقتصاد كميه كبيره لان بتوصل قريب من كوريكت دايجنوزس. بتشيل وايت كوت هايبرتنشن، تعمل ريبيتيتيف ميجرمنتس، بتديسكارد الفيرست واللاست ريدنج الموجودين اللي هو فيهم الوايت كوت هايبرتنشن، فبيديني المين ارتيريال بلاد بريشر ان اديشن، وده اللي بيستخدم فيه التريتمنت.
Definitely it correlates with the outcome better than the home blood pressure. But كل الجايد لاينز الكنديان جايد لاينز بتطلع كل سنه. يعني الكنديان جايد لاينز very important. The sprint trial was made largely in Canada and the measurements were ambulatory with the automated blood pressure instrument. الفرق بينها وبين الميجرمنتس العاديه 17 ملم of mercury. So if the same patient you get marked difference makes the diagnosis of hypertension a very cumbersome undertaking.
هو ما حدش يقدر يديناي ان الميجرمنتس اوف بلاد بريشر ده واحده من البيت فولز بتاع التريتمنت ان ما كانش يتعمل كوريكتلي. لما احنا شفنا عملنا البروجكت بتاعنا وشفنا البلاد بريشر في كل الاماكن في الجامعات ووزاره الصحه والمستشفيات التعليميه، لقينا في الواحده من اليونتس ستروك يونتس البلاد بريشر فرق ما بين كالبريتد نون كالبريتد 40 ملم ميركوري فعلا. عشان فور ذا سيك اوف. شكرا دكتوره غاده، شاكر جدا جدا. اتفضل.
Our next speaker, Dr. Yasser Baghdadi, Professor of Cardiology in Cairo University. He's going to speak about new drugs for hypertension treatment update.
Bismillah ar-Rahman ar-Rahim. Good morning, my dear professors and colleagues. Welcome to Qasr Aini meeting today. I'll talk about new antihypertensive medications that are on the pipeline, possibly will come to clinical use in the future. This is my agenda for today, a small introduction, why we need new drugs, the primary goal of the new drugs, pathophysiology of hypertension, the timeline, and a summary. Hopefully it won't take too long. The renin-angiotensin-aldosterone system is responsible mainly for blood pressure maintenance and the vascular tone maintenance. Modulation of the RAS system therefore interferes with the cellular processes and leads to high blood pressure, oxidative stress, inflammation, fibrosis, and hypertrophy. These conditions can cause fatal cardiovascular and renal complications. So why do we need new drugs for hypertension? The available antihypertensive drugs are very effective. They reduce the blood pressure and they manage a lot of our patients. But their main problem is their efficacy in the management of end organ injury is limited. And still we have a mortality related to hypertension which we want to decrease. Also, the RAS inhibitors, which are the mainstay of management of patients with hypertension, have some adverse effects, mainly related to hyperkalemia and hypotension. The primary goal of the new antihypertensive medication is focused on novel ways to fill the gaps in the management of patients with hypertension or with the current antihypertensive medications, hopefully to produce new drugs with less side effects and more efficacy and better end organ protection. As regards the pathophysiology of hypertension, as we can see, there remain mainly three systems related to the pathophysiology of hypertension. A system related to the natriuretic peptide system, another system related to the sympathetic output, and the third related to the RAS system that we have diagnosed. Each one of these systems has a number of receptors and a number of hormones related to the management and the maintenance of blood pressure. Yearly, new parts of these systems are discovered, and these parts are what we aim at using to manage patients with hypertension. The current antihypertensive management strategies include diuretics, RAS blockers, beta blockers, calcium channel blockers, and mineralocorticoid antagonists. These medications principally halt the harmful effects of excess angiotensin II and aldosterone release, which are mainly mediated through the AT1 receptor and the mineralocorticoid receptors. So what are the new antihypertensive groups and drugs that are available these days in the pipeline? The first is the angiotensin II receptor agonist. Angiotensin II is the central hormone in RAS, which produces vasoconstriction and has a vasodilatory effect through the AT2 receptor that's available. The expression of the AT2, the angiotensin II receptor, is maintained at low levels under healthy conditions. However, under disease conditions, such as renal failure, vascular injury, and myocardial infarction, its expression is markedly upregulated for endogenous protection of the body. Angiotensin II mediated vasorelaxation is believed to occur through the AT2 receptor and is facilitated through the nitric oxide synthetase and the nitric oxide signaling pathways. Currently, there are 4 AT2 receptor agonists under preclinical investigation. They have so far been shown in animal studies to be effective in the treatment of cardiopulmonary pathology, attenuation of myocardial hypertrophy, and effective in the treatment of myocardial hypertrophy and fibrosis. Another pathway or another group of drugs use the ACE2, angiotensin 1 to 7, and the MAS receptor protective axis. The angiotensin converting enzyme 2 is a member of the carboxypeptidase family and is similar to the ACE. It has a high affinity towards angiotensin 2 and cleaves the angiotensin 2, which is harmful, into angiotensinogen 1 to 7. Angiotensinogen 1 to 7. The angiotensinogen 1 to 7 activates a receptor, the so-called MAS receptor or MUS receptor, and this is a guanylate cyclase receptor pathway. And it has been found to reduce the pulmonary fibrosis and controls hypertension and cardiac remodeling, and has prominent antifibrotic, anti-inflammatory, and anti-apoptotic actions. There are a number of drugs that use this pathway. Some are being placed in clinical trials. وبدأوا حتى في الكوفيد era يستعملوها في management of patients with hypertension and pulmonary arterial hypertension, as well as peripheral vascular disease. A third group of drugs is related to the natriuretic peptide neprilysin pathway. As we know, natriuretic peptides, they cause RAS inhibition and decrease the renal sympathetic nervous system inhibition. They decrease the cardiac load and decrease the hypertrophy and the fibrosis that occurs. They result in vasodilatation, hypotension, and angiogenetic effects. Neprilysin inhibitors have been used effectively in patients with heart failure. Their use in patients with hypertension is under study, And so far, they have been very effective in both reducing the blood pressure and reducing the end organ and end target effects of the drug. And this is the use of ARNI in patients with hypertension. There's also another pathway similar to the neprilysin, which is stimulation of the soluble guanylate cyclase enzyme. And this is a pathway which causes vasodilatation and causes cardiorenal protection. Ongoing trials are now underway. Dual-acting bispecific peptides are another group of drugs, and the primary function is to mimic the action of the endogenous peptides and natriuretic peptides. So they are drugs similar to the natriuretic peptides that are naturally present in the body. One of the most important of these is sendritide, which is the first dual-acting peptides that activate the natriuretic peptide receptors A and B. And their biological action is mediated through soluble guanylate cyclase and causes natriuresis, vasodilatation, and renin and aldosterone inhibition. Studies are still underway. Antioxidant therapy. Antioxidants play a pivotal role in the progression of renal, vascular, and cardiac diseases. Vitamin D is emerging as a new antihypertensive medication with antioxidant properties. It's already started to be used in pulmonary hypertensive rats and has improved the survival and decreased the ventricular hypertrophy. Some antihypertensive drugs also have antioxidant activity and are currently attracting a lot of attention, including nebivolol and cardivolol. Non-steroidal mineralocorticoid receptor antagonists. The development of finerenone, which was found to be more effective than eplerenone in reducing the cardiac hypertrophy and proteinuria. These non-steroidal MRAs are under extensive clinical trials, now into phase 2 randomized clinical trials, and they seem to have less side effects of hyperkalemia as compared to the other MRAs that are present nowadays. One of the first aldosterone synthetase inhibitors, which is baxdrostat, has already been studied in a phase 1 study in patients with treatment-resistant hypertension and has been found to be very effective. Aminopeptidase inhibitors are another group, and they normalize the brain RAS and promote the cardiac function, inhibit hypertrophy and fibrosis in mouse models. They are so far potent and safe centrally acting antihypertensive agents still undergoing trials. Insulin-resistant aminopeptidases are another group. The angiotensin 4 receptor was identified in 2001. IRAP is another target, and the angiotensin 4 peptide is responsible for vasodilation, mainly in the pulmonary arterial endothelial cells. It has been found to reduce the blood pressure and the renal flow via AT1 receptors. So these are the new groups of drugs that are under investigation as antihypertensive medications, hopefully to be more effective and give better results overall compared to the current antihypertensive medication. The increased burden of hypertension and its associated complications has required the development of new classes of safe and effective therapeutic agents, as the currently available drugs, despite their efficacy in lowering blood pressure, have adverse side effects after prolonged use. Thank you very much.
Thank you, Yasser. A very difficult lecture. Dr. Mohammed, حضرتك
The main objective of using antihypertensive drugs is to prevent end organ damage, not just dropping the blood pressure. So this usually takes some time to prove that the drug drops the blood pressure, has tolerable side effects, and the most important step is that nephropathy cardiac affection and central nervous system affection, the events decrease. Until that is proven, then you cannot accept any of these drugs as a primary treatment of hypertension. We have two lessons very important that cannot be forgotten. The value of beta blocker in hypertension, which has been relegated to a third or a fourth class antihypertensive drug, and the value of drugs which elevate the HDL, which proved to produce hypertension after some time and have been cancelled completely from the pharmacopoeia.
Thank you, Dr. Mohammed.
Now, for the sake of time, we are going to move to the next speaker, Professor Dr. Dalia Remisi, which is going to tell us about the update of hypertension management guidelines.
Assalamu alaikum. Guidelines hypertension update. هو الجايدلاينز بتاعت الهايبرتنشن بقالهم فترة كسلانين شوية أو ما غيروش كتير، فاحنا مش هنلاقي حاجات كتير قوي نقولها. احنا مع ان انا اتخضيت بس لما قريت ان ان 10.8 مليون بيموتوا per year بسبب الهايبرتنشن. هو ده رقم مخيف، يعني تقريبا 11 مليون بيموتوا من الهايبرتنشن. 1 out of 5 are hypertensive، يعني في عيلتك كل 5 واحد هيبقى عنده hypertension. 7 out of 10 are not controlled. Guideline هو مش لازم نمشي عليه، بس it only guides us. It's a guide. طيب معلش السلايد ده زحمة ودمه تقيل، بس في كام معلومة أنا عايزة أقولهم. أولاً أنا اخترت الأمريكان الACC واليوروبيان. ليه؟ لأن هم دول اللي عادة بنمشي عليهم. في طبعاً الكنديان والانترناشونال سوسايتي أو هايبرتنشن وكل جايد لاينز كويسة، وفي الإيجيبشن بتاعتنا بتاعت 2016، بس أنا اخترت الاثنين دول بس هم اللي هعمل بينهم comparison. اللي عايزة أقوله إن لما نزلت الACC الأبديت بتاعهم في 2017 عملوا controversy رهيبة. ليه؟ لأنهم عملوا change جامد جدا. هم نزلوا الديفينيشن of الهايبرتنشن ل 130 بعد ما كانت معظم الجايد لاينز 140 على 90. فدي كانت حصلت من الأمريكان في 2017. قامت اليوروبيان عملت الأبديت بتاعها في 2018. واخر واحده اللي هي قلنا الانترناشونال سوسايتي اوف هايبرتنشن دي 2020. طيب ايه الجديد؟ احنا هنقول ثانيه واحده. في الميجرمنت، ايه الجديد في الميجرمنت؟ هم كلهم كل الجايد لاينز في العالم كله اجمعوا ان اهم حاجه في المانجمنت اوف هايبرتنشن از ذا ميجرمنت. لان زي ما الدكتوره غاده قالت هو ده اللي هيتبني عليه العيان ده هايبرتنسيف ولا لا. يبقى the emphasis on the accuracy of blood pressure ده ما فيش حد ما اجمعش فيها، ودي ما اختلفش فيها لا الامريكان ولا اليوروبيان. طيب تاني حاجه الاوت اوف اوفيس ولا الامبيولاتوري، مين اللي ناخد بيه؟ الامريكان قالوا اوت اوف اوفيس، الامبيولاتوري والهوم. اليوروبيان قالوا لا احنا بنعترف بالاوفيس بس زي ما احنا عارفين more than two or more readings on 2 or more occasions. يبقى الامريكان هم اللي طلعوا الاوت اوف اوفيس وانسيستد على الامبيولاتوري او الهوم. طيب ايه الديفرنسز بينهم في الديفينيشن اوف هايبرتنشن؟ ودي شويه مهمه قوي لان واحد هيليبل هايبرتنشن واحد هيقول عليه لا ده نورمال. الامريكان قالوا ان 130 على 139 سيستوليك و80 to 89 ده ستيج 1 هايبرتنشن. اليوروبيين قالوا لا 130 ل 139 والدايستوليك 85 ل 89 دول upper normal. طيب الامريكان قالوا ستيج 2 اي حد خلاص هم ستيج 1 يا 2 وال2 140 على 190 او اكتر. يبقى هنا الاختلاف الكبير في الامريكان لما they defined 130 على 130 ل 139 ده hypertensive. فهي ده الاختلاف عن اي جايد لاين تاني. اليوروبيان الاوبتيمال اقل من 120، النورمال 120 ل 129، الهاي نورمال هي دي الفرق. 130 على 139 في الاوروبيين ده هاي نورمال. في الامريكان ده ايه؟ هنا ده هايبرتنسيف. طيب الامريكان نفسهم اختلفوا عن الجي ان سي 7. في الجي ان سي 7 كانت ايه؟ 130 على 139 كان اسمها بري هايبرتنشن. دلوقتي هم خلوها ستيج 1. طيب الانترناشونال سوسايتي اللي هي في 2020 دي احدث حاجه، دي قالوا ايه؟ برضو اتفقوا مع الاوروبيين ان هي 130 لحد 100 ل 139 سيستوليك ده نورمال او هاي نورمال. طيب هنا بس المعلومه هنا المهمه في السلايد ده ان الامبيولاتوري هو ليه 3 ارقام لازم نعرف عشان نليبل هايبرتنسف في الامبيولاتوري، لان احنا قلنا الامريكان بيعترفوا بيه او الهوم. طب ايه هي الارقام بتاعتهم؟ ال 24 افريج يبقى اعلى من 130 80. الداي تايم اللي هو صاحي فيه، مش ضروري داي تايم المهم يبقى صاحي، 135 85. والنايت 120 70. اعلى من 120 70 في النايت ده يبقى هايبرتنسف. خلاص؟ طيب خلاص دي مش مشكله، دي الفروقات في الامبيولاتوري هو كلهم تقريبا متفقين ما عدا الامريكان الوحيد اللي اختلف عن كل الجايد لاينز. في الهوم خلاه اقل، في الكلينيك خلاه اقل، في الداي تايم والنايت تايم، حتى النايت تايم 110 65. هم الامريكان really are very aggressive. طيب هما الاثنين اتفقوا انه خلاص once diagnosed hypertension انا قست له الضغط صح وخلاص هو labeled hypertension، اعمل معاه ايه؟ لازم اعمل له risk stratification قبل ما ابدا العلاج. ليه؟ مين اللي هدخل معاه بادويه اجريسيف ومين اللي ممكن افولو فتره اطول. فالامريكان استعملوا الاي اس سي اللي هي السي في دي ريسك سكور، واليوروبيين استعملوا سكور كارديوفاسكولار ريسك اسسمنت. ليه؟ علشان لو هو هاي ريسك هنتريت على ليفل اقل. يبقى الاثنين اتفقوا ان لازم بعد ما define him as hypertension اعمل ريسك سكورينج. طيب هنبدا العلاج. طبعا برضو كله ما اختلفش على اللايف ستايل موديفيكيشن، وكلهم قالوا ان ده كور مانجمنت في اي عيان ضغط. ما ينفعش عيان ضغط على طول ادي تريتمنت من غير ما اعمل لايف ستايل موديفيكيشن. ايه هي؟ الويت لوس والدايت والصوديوم ريدكشن، بوتاسيوم سبلمنتيشن، فيزيكال اكتيفيتي، والمودريشن عندهم للالكحول. طيب هنبدا ميديكال تريتمنت. ميديكال تريتمنت برضو كلهم اجمعوا على الفور كلاسز بتاعتنا، الايس والاي ار بي، كالسيوم شانل بلوكر والدايوريتكس. هم ده مين؟ طب امتى استعمل بيتا بلوكرز؟ only on compelling indications. ما بستعملش بيتا بلوكرز ابدا as a first line. دي برضو كل الجايد لاينز اجمعوا عليها الا لو في compelling indication. طيب دراج واحد ولا اثنين؟ هم كل الجايد لاينز اجتمعوا على ان احنا نبدا باثنين. اليوروبيان قال اثنين initial treatment with 2 drug therapy for most adults with hypertension. whatever هو once diagnosed hypertension في الأوروبي بيدوا two drugs مع بعض. single pill combination برضو كلهم أجمعوا على السنجل pill single pill اللي هو combination. طيب إيه أبدأ بأنهي؟ initial therapy هنبدأ ب ACE inhibitor ARB مع calcium channel blocker or diuretic. طب لسه العيان مش controlled هزود الدايوريتك. طب لسه العيان مش controlled هزود spironolactone alpha blocker beta blocker or another diuretic. هنرجع تاني beta blockers بيبقوا added في حالة ان هو لسه resistant او في compelling indication. دي برضو ده اليوروبيان. طيب الانترناشونال سوسايتي اوف هايبرتنشن قال نفس الكلام بالظبط، ما فيش اي اختلاف خالص غير انه حط حته الريس. لو هو بلاك ريس بيحبوا الايس انهبيتور او الاي ار بي مع كالسيوم شانل بلوكر او كالسيوم شانل بلوكر مع دايرتك. طيب ايه ثريشولد؟ انزل لكام؟ الامريكان قالوا انا انزل. اليوروبيان وقفوا عند 130 على 80. اليوروبيان قالوا هدف نمبر 1 انزل على 140 90 up to 80 years of age. طيب above the 80 years of age 160 90. ده الاختلاف الكبير اللي بينهم وبين الامريكان، ان هم above the age of 80 هم اكتفوا عند 160 90. لو الدراجز البيشنت tolerated it very well ممكن ينزل اكتر، بس if the drugs خلاص العيان كده ده الماكسيم بتاعه leave a patient more than 80 years old عند 160 90. طيب patient once hypertension اوكي. الفولو اب بتاعه يبقى ايه؟ monthly interval. كلهم اتفقوا every month لحد ما يبقى controlled، بعد كده 3 to 6 months. هنا مفيش اي حاجه جديده خالص. في معلومه بس دي السلايد ده ابيت مهم، لان ده واخد العيان الدايابيتك، العيان الرينال، العيان اللي عنده coronary artery disease، هم كلهم اجمعوا الحلو قوي هنا ان ده اليوروبيان في الكدني ديزيز ما رضيش ينزل على 130 على 80. في الامريكان والانترناشونال سوسايتي اوف هايبرتنشن سمحوا بال 120. طب الكدني ديزيز اللي هو كيد جو قالوا ان ممكن ننزل ل 120 اقل من 120 على 80. لكن اليوروبيان انسيستد على في كرونيك كيدني ديزيز ما ننزلش على ال 130. واليوروبيان دايما يقولوا not less than 120 not less than 120. دي بيهتموا بيها جدا، فدي مهمه. والدايستوليك ثابت ان ما يقلش عن 70. طيب هنا بس السمري. احنا ايه السمري؟ مور اتنشن الميجرمنت، الاثنين اتفقوا ان accurate measurement ده مهم جدا. تاني حاجه اختلفوا اخد الهوم ولا الاوت ولا الاوفيس ولا الان اوفيس. لايف ستايل موديفيكيشن ما فيش حد اختلف في دي. الفور دراجز هم ما اختلفوش فيها. سنجل بيل كومبينيشن ما اختلفوش فيها. هم اختلفوا كمان في ايه؟ في التارجت اللي انزله. هنا دي بتاعت الكيدجو دي مهمه قوي بتاع الرينال، ان هم قالوا we can go safely below 120 بس insist ان لازم يبقى فيه individualization is very very important. كل عيان ليه الستوري بتاعته، ليه الطريقه بتاعته، ليه الارقام بتاعته. بس مفيش حاجه تاني. ثانك يو.
شكرا دكتوره داليا على المحاضره الجميله دي. For the sake of time we have to close this session. Thank you very much.
الدكتور عادل مش محتاج تقديم، كل الناس عارفاه، حبيب الجميع، هيتكلم
معلش هم غيروه. الاستاذ دكتور عادل اتريبي هيدينا طبعا محاضره شيقه جدا زي ما الدكتور جلال بيه قال عن البايفركيشن والتيبس اند تريكس، وطبعا هنستمع لحاجه شيقه. اتفضل دكتور عادل بيه.
انا بس بعد قبل التايم يبتدي عايز اقول كلمتين شكر يعني للقصر العيني. الحقيقه يعني الواحد بيبقى فخور دايما وهو موجود في معقل الطب في مصر، وعمري الحقيقه ما دخلت القصر العيني وحسيت اني شخص غريب. بالعكس، الواحد بيخش القصر العيني وهو منسجم جدا. الجيل بتاعي ابتدى بخالد سرور، ثم حسين رزق، ثم وفاء العروسي وسليمان غريب وحسام قنديل ومحمد يعني محمد عبد الغني، ثم مجدي عبد الحميد اخرهم. والحقيقه الجيل ده يعني طور في اسم القلب في القصر العيني وغيره وزود العلاقه الطيبه الحميمه اللي بين الجامعات المختلفه. ده بالناهيك بقى عن اصدقائي الاعزاء اللي خارج رؤساء الاسم، من الدكتور ايمن قداح والدكتور ياسر، يعني ياسر حبيبي، والدكتور وليد عمار، والدكتور محمد الرملي، وسامح سلامه اللي يعني انا مش عايز اقول اسامي لان تقريبا كل اسم القلب حبايبي ومش عايز انسى اسم فيهم. الحقيقه انا هتكلم عجاله بقى عشان ما ناخدش وقتكم على البروفيجنال ستنتنج، الرولز بتاعته according للبايفوركيشن كلاب ريكومنديشنز في 2021 والتعديل البسيط اللي حصل في 2022. اول حاجه قبل ما نشتغل بايفوركيشن لازم تو ريسبكت 3 ثينجز: الاناتومي نفسه وندرسه كويس، الريسورسز اللي عندي، ما ينفعش اقول انا هعمل بايفاس وهعمل مش عارف بروتابليتور، انا ما عنديش الحاجات دي، فلازم الاول تعتمد الريسورسز، ولو مش عندي مش مفروض اشتغل، والايفيدنس اللي ورا كل خطوه بناخدها. اول حاجه في الاناتومي ان انا لازم تاسس الثري دايمترز، البروكسيمال والديستال، ونشوف الالاينمنت قد ايه والانجلز قد ايه، وكمان لازم اعرف ما هو الكومبلكس بايفوركيشن او ما هو الترو بايفوركيشن بنطلق عليه. ترو بايفوركيشن ان هو يبقى اكتر من 50% ليجن في البوث مين برانش والسايد برانش، بقينا كده ترو بايفوركيشن. ولازم يكون السايد برانش اكتر من 2 مللي، ولازم يكون كمان البيرن اوف 3 اسروما بتكستند اكتر من 5 مللي، وفي بعض الاقاويل 10 مللي من السايد برانش اوستيوم، وان الحته دي بتسبلاي ا بيج مايوكارديوم. ما ينفعش اقول ان ده بايفوركيشن مهم ومش سبلاينج ا بيج اريا اوف مايوكارديوم. الرول طبعا دي مش هنتكلم عليها، المدينه كالسكيشن اللي هي سهلت لنا اسامي كتيره في التقسيم، لكن اهم رول في الدايمترز ان لما بحط ستنت بحطه على الديستال فيسل مش على المين فيسل، وان عمر ما المين فيسل كان قد الديستال فيسل، لازم المين فيسل بيبقى اكبر شويه من الديستال للبايفوركيشن. وعشان احسب ايه ده، وعشان احسب مقاس الاوريجينال فيسل بيبقى السم اوف دي 2 ودي 3 تلتين السم بتاعهم، وساعات بعمل بالعكس، يعني مثلا انا الاقي ال دي 3.5 والسيركمفلكس 3، يبقى 6.5 في 2 ب 13، يبقى انا المفروض اكبر الليفت مين ل4. او العكس بقى، ساعات انا باخدها بالعكس، انا مش عارف مقاس المين فيسل بتاع ال دي، لكن شايف الدياجونال 3 مللي ومثلا والال دي 3.5، يبقى اعملها بالعكس، يبقى اتوقع البروكسيملي يبقى ايه. تالت حاجه مهمه جدا في البلاك ديستريبيوشن ان البلاك عمره ما بيبقى عند الكراينه، عمره ما يبقى عند الكراينه في مكانها. ما اعرفش بتشاور دي ولا لا، المهم يعني ان الشير ستريس بيخلي الكراينه دايما فري اوف ليجنز. تالت حاجه مهمه اللي هي امتى نعمل وايرنج في البايفوركيشن انجل. كل ما البايفوركيشن انجل بتكبر كل ما يبقى البوسيبيليتي ان انا اخشها اصعب، وبالتالي المفروض اعمل لها وايرنج قبل ما احط اي ستنت في الليفت سيستم. في الاكيوت انجلز والاوستيوم كويس جايز ساعتها ما احطش واير، ودي بقى اللي هنقول شويه الرولز بتاعتها. يبقى السؤال بتاعنا شود اسايد برانش روتينلي بي وايرد؟ ات شود بي روتينلي بي وايرد، لكن في بعض الاحيان الوايرنج مش مطلوب لو الاوستيوم كويس. تاني حاجه بقى كنا متربين عليها ان الهيدروفيليك وايرز دول او البوليمر كوتد وايرز ما تعمل لهمش جيلينج، ما تحطهمش في سايد برانش. الكلام الجديد ان العكس صحيح، ان البوليمر كوتد وايرز ار مور ريزيلينت للشير ستريس، وممكن تحطهم في السايد برانش جيلينج، وده كلام جديد